इंट्रोड्यूस नितेश। आप काउंटडाउन शुरू कीजिए टेक टीम को बोल के, देन
Okay,
वी
sir.
गो।
Please start in 3, 2, 1.
Am I audible?
यस, यू आर ऑडिबल।
Okay. So let's begin with the this today's meeting. So good evening, everyone, uh, and welcome to this Bare Eyesight meeting. And we are delighted to have you join us for this focused clinical exchange. Tonight's session brings together leading retina experts to explore real-world strategies and treatment durability and evolving approaches to fluid management. At Bayer, we are proud to support platforms that foster peer learning and evidence-based care. Thank you for being part of this dialogue. And let's begin with the speakers today. Uh, our first speaker is Debarati ma'am. Ma'am is a consultant ophthalmologist at Siliguri Greater Alliance Eye Hospital, and she's a specialist in vitreoretinal and ROP. She is trained at Shankar Netralaya and she is skilled in advanced retinal imaging, including OCT angiography. Ma'am has been instrumental in community eye care and CME programs, delivering expert care for diabetic retinopathy and ROP while promoting early diagnosis and preventions. Today, ma'am will be speaking on NMD, critical information for clinicians to enhance patients' outcome. And today, our second speaker is Dr. Nishta Yadav. Ma'am, we are pleased to welcome you. Ma'am is a vitreoretinal surgeon currently affiliated with Patliputra Gastro and Eye Care, also Sri Sai Eye Hospital at Patna. With Ma'am is experienced with advanced fellowship training at Joshi Eye Institute and Shushutai Foundation. She brings expertise in complex retinal surgeries, ROP management, and innovative molecular procedures. Ma'am is awarded speaking on the evolving role of aflibercept in PCB, APVRS insights, and comparisons with anti-VEGF agents. So let's begin with the first topic. Debarati ma'am, welcome you to start your topic, ma'am.
So thank you, Bears, and thank you for giving me the opportunity to speak. So I hope I'm audible.
Yes, ma'am, you're audible
Yes,
and your
ma'am.
slides are
And
visible.
my slides are visible too.
Yes, yes.
Okay. So today I'll be speaking on the relevant things that a clinician should know while treating neovascular AMD or wet AMD. So as you know now, AMD is one of the leading cause of severe vision impairment. It is estimated that around 196 million people are being affected with AMD, both dry and wet combined, and it is projected to increase by around 288 millions by the year
Ma'am,
2040.
sorry to
Thus,
interrupt. I think your video is not on, I think. Is
okay,
it
sorry,
possible?
sorry, sorry. Yeah. Just a minute. Okay. Is it visible now? The video is visible?
Yes.
Yes, ma'am.
Okay, sorry. So we have just now spoke about the burden of the disease. Now they mainly present with symptoms of central scotoma and central blurring of vision and vision distortion, and which affects the quality of life. Stages, it can result right from early, intermediate, and severe, where severe can be either in the form of RP atrophy in dry AMD and in the form of hemorrhages and massive exudation in wet AMD. So diagnosis is simple. It is based on clinical examination and other ancillary tests like OCT, FFA, ICGA, and now recently OCT angio. So this is beyond the scope of discussion today about the diagnosis of AMD. So mainly what is important here is that timely diagnosis is very important, as appropriate treatment with anti-VEGF can prevent irreversible vision loss. So what is the main pathogenesis behind wet AMD is that here VEGF drives formation of an AMD. So normally retina is protected by the neurosensory retina is protected by RPE Bruch's membrane. So when there is breach in this protective layers or there is increase in VEGF, it results in subretinal or sub-RP neovascular proliferation, mainly via pathways of VEGF receptors. So main VEGF responsible for this pathway are VEGF-A platelet inhibitory growth factors, which mainly act via the respective pathways and causes angiogenesis and vascular leakage. So it is important because drugs target in this pathway and prevent angiogenesis and vascular leakage. So our main focus for today is aflibercept, which has a effect on both VEGF receptors 1 and 2 because it is a recombinant fusion protein combined of VEGF receptors 1 and VEGF receptors 2, and it has very high affinity for following VEGF, which has effect on angiogenesis and blocks this pathway. Now, what is the role or why is aflibercept is a choice in wet AMD? So, various clinical trials and real-world evidence support the use of aflibercept in treatment of wet AMD. So, one of the pivotal study is Altair study, which evaluated the safety and efficacy of intravitreal aflibercept treat and extend regimen in treatment-naive patient with wet AMD. So here, 3 monthly loading dose of 2 milligram aflibercept was given. Thereafter, at the end of 4 month or week 16, patients were randomized 1:1 to either aflibercept treat and extend regimen by 2 weeks or by 4 weeks. So what was observed here was that both the groups' outcomes were comparable in terms of number of injections, in terms of vision, and in terms of reduction of central retinal thickness. So here you can see both in treat and extend group of 2 weeks and 4 weeks, vision has improved by around 7.6 letters and 6.1 letters respectively, and mean number of injection was similar in both the groups. So this is the main vision acuity at the end of 52 weeks and 96 weeks. Both are almost equal. And also 96.2% of patients extended up to 4 months, and this is maintained at the end of 96 weeks with aflibercept. Another long-term study which observed long-term efficacy and safety of aflibercept for around 4 years was VIEW-1 extension study. As we all know, VIEW-1 study has elaborately studied on aflibercept efficacy and safety. So after completing VIEW-1 trial, which studied for 2 years, patients were further enrolled for extension study. And here, patient received 2 milligram of aflibercept in a modified quarterly injection schedule followed by 8 weekly interval dosing. So here also we can see that vision was maintained by around 7.1 letters by the end of 4 years, that is 212 weeks. Another study by FRB has also documented stability with treat and extend regimen with aflibercept. So Moorfield study has also documented similar result with maintenance of vision. Here also you can see there is maintenance of vision acuity at the end of 4 years. So another group, Jaggi et al. And also reported the same benefit with treat and extend regimen. Here the difference was that no initial loading dose was given. Even without any initial loading dose, vision was maintained at the end of 4 years by aflibercept. So thus, All the studies with RCTs and real-world evidence support long-term safety and maintenance of vision with aflibercept. So why is aflibercept a choice even in PCV? So the main study that we know with PCV is PLANET study. So as we know now, PCV is very much common in Asians than it is thought to be. And what has PLANET study document is compared is that they have compared monotherapy with aflibercept versus aflibercept and active PDT. And at the end of 52 weeks and at the end of 96 weeks, they have found out that monotherapy with aflibercept was non-inferior to combined therapy with aflibercept and PDT. Participants in both the groups had shown reduction in central subfield thickness at the end of both 52 weeks and 96 weeks. So this is a similar graph that shows the following that I have said. In both the treatment groups, more than 82% of the patients showed reduction of active polyp. Other trials, both real world and RCTs, also support aflibercept monotherapy is almost non-inferior to combined therapy, or they maintain vision equity in long follow-up even with patients of PCV. So another study by Indian group has showed that aflibercept is effective even in recalcitrant PCV. So patients of PCV who were earlier treated with other anti-VEGF had repeated recurrence or were not responding showed benefit with aflibercept. So coming to the safety, so as we know that aflibercept is the safest drug with very minimum rate of retinal vasculitis and occlusive retinal vasculitis. Thus, overall, we can say that aflibercept is both safe and efficacious in both PCV and AMD. So coming to the clinical cases, so I'll be speaking on two clinical case scenario. So here in case 1, you can see that this is a fundus photograph showing subretinal hemorrhage and some amount of exudation. In the respective B scan, you can see there is intraretinal fluid, subretinal fluid, there is a PD, along with that there is notch in the PD and some type 1 neovascular membrane. In the corresponding structural or the en-face ACT, you can see that there is this irregular RPE, which is typical of PCV. So here this patient had received 3 doses of aflibercept, and at the end of 3 months, you can see that there is reduction of both IRF and SRF, but however, the PED is still there. The vision has improved from 660 to 629 parts at the end of 3 months. So another case where a patient presented with vision of 660 and on examination the patient had exudation and some amount of subretinal hemorrhage. I did not document the fundus photo. So here there is subretinal hemorrhage, along with that there is PD and some amount of drusenoid PD also. So with subsequent injections, the subretinal fluid has reduced, and this is the last scan where you can see that subretinal fluid have disappeared at all, and the patient's vision has improved to 612. So thus, we can say that aflibercept is very much safe and efficacious, and vision is maintained even in the long run. So thank you, and thank you, Bear, for allowing me to speak.
Thank you, ma'am. Thanks for your wonderful talk. Uh, can we take questions, or we can move to next talk? Then we can take questions at the end.
Yes. Yeah, we can move to next talk for the sake of the time, and then we will have a 10-minute of question answer session. Yeah.
Okay. So now I invite Nishita ma'am, and I'll be sharing the screen for that.
Good evening, everyone. Am I audible?
Yes, ma'am.
Good evening, everyone, and thanks, Bear, for giving me this chance. to speak on PCV. So Mr. Nitish will be sharing the screen.
Just in. So is it visible, ma'am?
Yes. Can you remove this screen which is at the yes, thank you. So I'll be discussing on the evolving role of aflibercept in PCV and also discussing the new APVRS guidelines which was issued in 2025 and comparing aflibercept with other anti-VEGF agents. So next slide. Next. So
Just in.
according So according to this, no, the previous slide, huh? According to this APVRS guidelines, which was updated in 2025, it has mentioned the diagnosis of PCV. Initially, generally, we do, after seeing the fundus, we do perform the spectral domain or sweat source OCT. And the criteria on that, three major criteria they have taken into account for suspecting PCV, not for confirming, for suspecting. That is a sharp peaked PED and then sub RP ring like lesion seen under that sharp peaked PED with on fast it shows RP elevation. So if it is suspected, then we have to go for multimodal imaging with fluorescent angiography, ICGA being the gold standard, or OCT, either spectral domain or SSOCT, and OCTA. So combination of these and we confirm the diagnosis of PCV. Then we go for the treatment part. So they have given the consensus on the treatment part. Either we have to go with anti-VEGF monotherapy or combination therapy of anti-VEGF with PDT. PDT, where in the clinical setting where it is available, you can also go for anti-VEGF with PDT and then monitor the response on OCT and with or without ICGA. So if there is complete regression or the SRF is stabilized, it is not increasing over time, then you can gradually extend the interval of treatment by treat and extend regimen, which I'll be discussing further. And if the fluid is persistent or recurrence is there, or you can see newer vascularization activity, then we need to shorten that treatment and extend regimen, or we have to combine it with anti-VEGF and PDT or switch to some another anti-VEGF. If there is a large submacular hemorrhage, then we cannot treat. Last slide. We have to go with the pneumatic displacement with or without vitrectomy or with or without TPA. And if there is active extrafoveal polypoidal lesion, we can try for thermal laser ablation along with anti-VEGF. Next slide. So what the guideline says that monotherapy with anti-VEGF treatment is effective in many cases of PCV and it can be used initially as monotherapy, and they have reached the consensus score of 95. 66% of the people in that who are making that guidelines, they have strongly agreed to this point and 29% agreed to this. So to date, there are no data which is exploring whether faricimab or brolucizumab monotherapy are non-inferior to combination therapy in patients with PCV, but we have number of data and RCTs and real-world trials on aflibercept doing the same. Next slide. So first we need to know the types of molecules which are available for the treatment of PCV. We know the aflibercept, brolucizumab, ranibizumab, and faricimab. Among these, at least aflibercept, brolucizumab, and ranibizumab, we all have used it. Faricimab may be the costlier one. Everyone must not have used it. So we should know mainly the molecular property. So KD value is mainly the binding affinity, and it is mainly inversely proportional. So lower the KD value, more will be the binding affinity of these molecules to the VEGF-A receptor. So among these, we can see that aflibercept scores lowest. So it has strong binding affinity to the VEGF receptors. Then coming to the half-life, among all these four molecules, aflibercept have higher half-life. Half-life is the concentration after which it becomes half of its doses in the vitreous. So it is highest in aflibercept. Then coming to the equivalent molar dose, it is the relative number of molecules which is required for that drug. Lower the number of the molecules, lower will be the side effects. So for the same amount of dose, aflibercept and ranibizumab, they are lower number of molecules which will be there in the vitreous. So it is much safer. Then the number of targets, we all know aflibercept acts on multiple targets. They act on 4 targets. Brolucizumab, ranibizumab, they act on single target, and faricimab on the dual target, that is VEGF and Ang2. And among potency also, this aflibercept it scores better than other drugs. Next. So in 2016, these pivotal studies with aflibercept, they have demonstrated that PCV can be treated similarly to neovascular AMD. So actually, the PCV is mainly the subtype of neovascular AMD only. So in View 2 study and Planet study, as already has been described by Debrati ma'am, these two studies, they have taken into account both PCV and all the neovascular AMD patients, and they have seen that patients with PCV and patients with NMD without PCV achieved similar vision gains with aflibercept monotherapy. And in Planet, they have compared the aflibercept monotherapy with combination regime, that is aflibercept with PDT. And they have found that visual gains were more or less similar. And in patients who have scored for this rescue therapy, PDT was done in those patients. Next slide. So Planet, it was a prospective double controlled randomized trial, and it was double masked trial, and it one arm was aflibercept monotherapy and another was aflibercept plus active PDT in patients of PCV. So initially 3 monthly injections were given for 0, 4 and 8 weeks. Then randomization was done at week 12. The patients who did not require the rescue treatment or did not fulfill the rescue criteria, they were given fixed dosing for after 8 weeks. And those who required the rescue those who came under the rescue criteria, they were given aflibercept 4 weekly with sham PDT in one arm and aflibercept 4 weekly with active PDT in another arm. And primary endpoint was seen at week 52, and then change in BCVA with safety outcomes were measured. Then from 52 weeks to 96 weeks, the patients who did not require the rescue treatment, they were kept on treat and extend regimen. So treat and extend regimen was for 1 week or 2 week. And those who fulfilled the criteria for rescue treatment, they were again given 4 weekly aflibercept, which sham PDT in one group, and in another group combination therapy was given. And again, the results were finally noted at week 96. Next slide. So in Planet, vision gains were similar in both the groups, and even in year 1, number of injections which were given, mean number of injections was around 8, and year 2 with treat and extend regimen, the number of injections decreased and it was around 4.6 on an average, that is around 5 injections. So obviously this has shown that with this regimen we can also decrease the number of injections and burden on the patient. Next slide. And even if the patient was on treat and extend regimen, they maintained that vision gain which was there in the first year with reduced treatment burden. Next slide. So Planet study, it has mainly included only PCV patients among neovascular AMD. In Altair, both the groups were taken, both PCV subgroup and non-PCV subgroup, and they have mainly compared the treat and extend regimen. 2 weekly and 4 weekly interval was seen, and in we can see that in year one it is almost comparable. In 2 weekly extension and 4 weekly extension, number of injections were compared in year 1 and year 2 in PCV group also and in non PCV group also. So we can follow that 4 weekly interval gap for giving aflibercept. Next slide. So similar proportions of patients with or without PCV were extended to periods of more than 12 weeks by week 96 with aflibercept 2 mg. That means that disease-free interval in more than 50% of the patients with or without PCV, they had disease-free interval of more than 12 weeks. So we can, in after some time, we can also wait for 12 weeks free period of not giving injection and just observing the patient. Next slide. So another study was done by Maruko et al. And it has also shown similar outcomes with aflibercept 2 mg treat and extend through 2 years regardless of the neovascular AMD subtype, and there were reduced treatment burden on the patient. Next slide. So real world studies done by Hosokawa M et al. And Morizine Hosokawa M et al. In 2018. They have also shown the durability of aflibercept with vision gain, and also the number of injections were less. They have also included the treat and extend regimen in this. So one thing we always consider while looking for this, uh, mainly that our PCV has regressed, is mainly on ICGA. That will be the final confirmation where we can see that the complete polyp regression has happened or the polyp is not leaking. So various studies from 2015 to 2017, they have shown that aflibercept works on this complete polyp regression also, and a higher percentage, more than 50% of the patient in their study, around 60 75, like these percentage were seen in patients who had complete polyp regression seen on ICGA. Next slide. So now we are comparing this aflibercept molecule with faricimab. So aflibercept, we know that major trial was this Planet, and for faricimab, Salvin is the study which is ongoing. The difference is in the design, first of all. That means the Planet is double masked. It was randomized, controlled, multi-center study. Salvin is also multi-center, but it is single arm and open label. There is no comparator group in this. While in Planet group, we already know there was a monotherapy group and another was aflibercept with rescue PDT. So in Planet, we had double masked. Patient and investigator did not know at which group was allotted sham and which group was in given PDT. But it is not so with Salvin study, so it is not so reliable. Planet followed monthly injection with 3 loading doses. Salvin followed monthly injections with 4 loading doses. Primary endpoint in Planet was non-inferiority of aflibercept monotherapy versus aflibercept with rescue PDT with change in BCVA from baseline to week 52, and Salvin studied for week 40 to 48 weeks. On polyp assessment, Planet did ICG reading, and they have seen for complete regression of polyps or absence of leaking polyps at week 52. Whereas in Salvin, they say only 7 total included patients were 104. Out of this, only 77 patients had confirmed diagnosis of PCV by CRC at baseline. So it is not so convincing. And still the trial is going on. Let's see what happens at end of this trial. Next slide. Next. And in this Salvin study, they have also they have not mentioned any criteria from where like how they have followed the treatment free interval. For some patient, it was individualized. For some patient, they followed 8 weekly treat and extended regimen. For some, they followed 12. For some, 16. And for after a year, they have followed 20 weeks of injection free interval, and they have not mentioned the criteria how they have followed up those patients. So more than 50% of the patients were assigned to faricimab 20-week dosing interval at week 44 to 48. So exactly the proper protocol or criteria has not been mentioned. Next slide. Now Hara et al. They have compared aflibercept with faricimab, so in PCV patients after 3 loading doses. So what they have found, although the total number of allotted patients in aflibercept group were less, out of 60 they have allotted only 24 people, and they have given aflibercept to only 24 people. Rest received faricimab. So number of people in this aflibercept group were low, but still they found out that BCVA significantly improved in aflibercept group at 3 months, and there was no significant improvement in faricimab group. So numerically greater with aflibercept in proportion of wise were more, and on OCT also they have shown that exudative changes were less in faricimab group, and it has resolved much more in aflibercept group with complete resolution of polypoidal lesions on ICGA also, especially in aflibercept group, and it did not resolve in faricimab group. It was not significant in faricimab group. Next slide. So what they concluded that both intravitreal aflibercept and intravitreal faricimab treatments are effective in reducing the exudation and thickness in PCV patients, but aflibercept was more likely to eliminate the exudative changes and improve the visual outcome. Next slide. So this was one of my patient with PC diagnosed with PCV. We can see the sharp peaked this PED and hyperreflective thing inside that, and this was pre-treatment. And second picture shows this was at the end of 3 months after 3 doses of aflibercept. That height of PD has also decreased. The subretinal hemorrhage has also decreased from the pre-treatment part. Next slide. So this is one of my patient with peripapillary. There was PCV element, and after I think so, this was after 4 doses that and 4 monthly doses that this has reduced, and the PD has also reduced, and the visual acuity in this patient has reached up to 612. Next. So here we can see multiple PEDs with hyperreflective spots with subretinal hemorrhage, and these patients, this patient was on first 3 loading doses, and then it was on PRN regime. So total till now he has received 6 injections of aflibercept, and this was the picture which was taken recently 15 days back, and there was complete reduction in height of PED with resolved hemorrhages. I don't have the fundus picture right now. Next case. And similar, this case was of multiple PEDs. We can also see the notched PEDs with hyper-reflective ring-like structure under that PED, and it was diagnosed as PCV, and this was after 3 doses of aflibercept, 3 monthly doses, and this was taken at end of 3 months. Next slide. So as we all know this molecule since long, and more than 90 million doses have been sold since its launch. Many RCTs and real world studies are on aflibercept, and we all know this drug well. And there is not only, this is not only used for PCV or neovascular AMD, we have also used this for BRVO, CRVO, DME, and neovascular AMD. In Japan, it is also given for NVG. ROP we are not using. I'm not using for ROP, but in countries like USA, Switzerland, and Japan, it has been approved for ROP also, and it has lower rate of intraocular inflammation, no occlusive vasculitis or any inflammation which we have seen with this drug, and rate of endophthalmitis is also very low. So adverse effects are very low, systemic effects are very low. So obviously this safety profile and efficacy has been established all across and in many countries. So we know this drug has done well throughout, and I feel very safe when I use this drug, especially for PCV, AMD, and also for cases where the fluid is persistent, recalcitrant, in chronic diabetic macular edema, and I've seen the wow effect which this drug gives. Thank you.
Thank you, ma'am, for the wonderful talk. And now the platform is open for the discussion. If I would like to request from our audience and speakers, if there is any question, kindly ask. So it will be yeah, I think we are good to close now as there is no question. So it's a very interactive session today, ma'am. Very interactive discussion. And I would like to request both of our speaker, Dr. Devrati madam and Nishita ma'am, for such a wonderful talk. And thank you very much. Thank you very much for your participation. And we are good to close now. Thank you, ma'am. Thank you, both of our
Okay,
speakers.
thank you, Saurabh.
Yes.
Good
Thank
night.
you, ma'am. Good night, ma'am. Good night. You wanted to tell something, ma'am?
Thank you. Thank you.
Welcome, ma'am.
Sir, can we close the session?
Yes, yes.
Okay, sir. Thank you.
All are in mute actually. Okay, okay, you can close. Yeah.